All right, well, let's go ahead and get going. Welcome. Good morning, everybody. Welcome to the EQIP subgroup meeting. I think if you saw my email with the slides last night, I did make a comment about the state employees. I just wanted to give a shout out to all of them who've been dealing with the cyber attack. They've been communicative and they're working through the problems, and we appreciate you. I know this last week has not been easy for a lot of you, so we do appreciate you and recognize it. And I know for some of the healthcare practitioners who've dealt with this kind of thing in the past, we know how horrible it is to deal with. So we just wanted to say something about that and thank you for your public service and your work on that. So if you could do me a favor, and if you are not talking, could you please mute yourself so we can go forward. This is the EQIP meeting. I did want to make a comment that we are doing meetings with folks who have expressed interest in adding codes, Prometheus codes or other codes or lines of specialties to EQIP for 2023. And we had a notice for you to send something in by this meeting. Obviously, there's going to be some flexibility around that. We are happy to set up meetings, and we've had some. I think folks from the HSCRC, myself, Jessica, we're all very happy to do that. And we do have some scheduled, and we have more that are coming, but we really need to know sooner than later, given the timetable that we're dealing with. So I just would ask that folks please reach out to us if you're interested or considering adding anything. If you don't ask, it's not going to be added. And this is a really cool opportunity. So we should at least explore it and see if it makes sense for new specialties. I do know that we are trying and working on meetings with ophthalmology and urology. We're looking at adding some of the codes related to hospitalists. We're looking at adding codes to the bundles that we currently had, like ortho. But we really want to have discussions with everybody and anybody who's interested. And the HSCRC has been working very hard with the emergency room doctors as well on their proposal. So, but again, if you're interested in adding, now is the time, don't wait. So having said that, I'm going to turn the meeting over to Jessica from CRISP, who is going to start off this morning's meeting. So Jessica, it is all yours.
Thank you, Jean. Good morning, everyone. So we have actually a pretty light agenda today. I'll be just jumping in and talking about some program administration and enrollment updates, and then I'll hand it off to Maddie, who will talk about the quality methodology and benchmarks. So just to start, as a reminder, where we are in the EQIP enrollment process. As you all are aware, we spent most of the summer and fall getting all of our care partners enrolled in the system, finalizing our episodes and interventions. There was some auditing and thresholds that needed to be met, and we appreciate everyone going back to their lists and tweaking as needed. And we also sent that final care partner list to CMS. We've actually received the first round of vetting results, which is available in the EAP portal. And as we get additional results, they'll be updated. Currently, we're in the last step before start for January 1st, and that is in the signature for the care partner arrangements. So as you guys are aware, hopefully you were sent this information, and we need everyone to sign off on that to be considered enrolled into the program with that December 31st deadline.
Hey, Lori, sorry. Let me turn down my Zoom meeting. No, don't. It's one that I know Karen Burgess was going to attend with me, but she's got a.
You can
okay.
mute yourself if you're not speaking, so I would appreciate it. Thank you. Go ahead, Jessica.
Okay.
Okay.
So to take a step back, hopefully everyone is aware that the arrangement that the state HSCRC has with CMS does require for an executed care partner arrangement with each individual care partner in order for incentive payments to be distributed by our CRP entity, which is UMS in this case. So the HSCRC did create a standard care partner arrangement. Again, that's required for every individual care partner to participate in an EQIP entity. These contracts were sent via a Dropbox link, I believe the first week in November, in which you can view and download those individual agreements. Per feedback from this group, we actually sent that link just to the admin proxies and lead care partners, which means that those individuals are responsible for disseminating the agreements and obtaining signatures from the individual care partners. Signed copies should be sent back to equip@umm.edu, so not that Dropbox link, but please send it directly to that email prior to December 31st. We are in contact with them and they will update us about the status of those signatures. If there are any questions about the program or even the documents, please direct all of them to the CRISP inbox, so that equip@crisphealth.org, and we'll make sure we filter it down to the right person. So where we are today, so this number is a little bit small, but I'm still very optimistic. So as of the 7th, which I believe was Tuesday, we have 3% of all of the care partner arrangements that have been received and signed. Keep in mind, we have, I believe, just over 2,400 individual care partners within the program. However, what we've noticed is a lot of the entities are gathering all of their care partners at once and then sending them rather than having them trickle in. So we actually have 23% of the entities, or 12 entities, with nearly all of their care partner arrangements signed. So that's the good news. And we do have some very large organizations, so we know the lift is heavy to kind of gather all those signatures. Starting today, all of the admin proxies and lead care partners will receive a summary email basically saying, here's your percentage of completion, with the link to EAP. And in EAP, you will be able now to see on the care partner dashboard the most recent signing status. So if you're uncertain if something has been received, again, that will be updated weekly, and we'll let you know about your signing percentage in order to hopefully get everyone signed and squared away by the 31st. Before I move off of care partner arrangements and the signing, is there any questions that we can help answer? Okay, great. And just other FYIs, there is a training and user guide available on the HSCRC website. You can see that here, as well as the policy technical user guide. So those are great places to start if there's questions, but of course you can always direct any additional help to our EQIP inbox. The Prometheus episode codes, so this is more of a little bit of a deep dive, are available upon request. So again, please contact that equip@crisphealth.org. Sorry, too many of them. And we will be able to get you those codes. You won't be able to replicate the Prometheus model from those codes, but it will provide a little bit more detail if you're looking to do some analysis on your own. And finally, throughout this process, whether you're interested in next year, whether you're enrolled now, if there are any questions, the CRISP are always available to meet one-on-one to answer any specific questions or review data. We're here and available as needed.
Hey, Jessica, it's Dr. Grasso. Speaking of data, when do we get our target prices and access to our data for analysis?
So we're expecting that to be available within EAP towards, I would say, mid to end of January. We will be sending some data to you guys via email, just because we realize it's very close to start and we know that there's been a great request for that. But the actual data will be available for your viewing towards the end of January. I don't have an exact date.
We're starting into this great new adventure completely blind from a provider standpoint. We have no idea what our target price is. We have no idea what our data is. We've not been able to do any analysis, and we're just hoping we're going to win, right?
So just to add a little bit more there, your baseline data will be available the first week of January for full claims download in EAP. We're running up against some data sharing limitations because we do not have all of your providers signed on their care partner arrangement saying that they will participate and consent for their data to be shared into the program. So it's a little bit of a chicken and the egg issue. We don't know what providers would like their data shared. So we have to wait until that care partner arrangement process goes through to ensure that we are being good stewards of PHI, and then baseline data, including those target prices, will be pushed out in EAP for all EQIP entities, including the full claims download. And then, as Jessica mentioned, we will start to push out more performance insights later into January.
Thanks, Maddie. That's really helpful. I actually was wondering if we're going to have only individual provider views through EAP, or if we will be able to roll it up by entity and see how certain entities are doing or certain medical systems are doing. Like, what's the roll up, roll down look that we're going to be able to have?
Yeah, great question. You'll be able to roll up to the EQIP entity level, and then it will break out to a by NPI view where feasible. So there are some things that are less feasible, such as the quality metrics, and those will not break out by NPI, but you will be able to roll up to the EQIP entities that you are an administrative proxy for.
Thank you.
Sorry, Jessica, I'll turn it back over to you, but I wanted to clarify on our data sharing there.
Sorry, anything else from the enrollment or program admin side? Any questions before we move on to quality? Okay, so actually back over to Maddie.
Thanks, Jessica. So we did want to revisit the EQIP quality methodology. We looked at this in January of this year, but we wanted to give a refresher on how this will be calculated, and then also mention that benchmarks or your baseline performance for your EQIP quality, or for the quality measures in EQIP, will be available in that early January release that I just mentioned. So that first week of January, we'll push out baseline insights and available detail to EAP performance dashboards. So we're going to walk back through some of the EQIP quality methodology and then look at performance thresholds for scaling and for scoring, and then also give you some summary statistics for what our EQIP entities are coming in at for the first year. Again, all of this is contingent on the final care partner list. So the final listing of who actually signs those care partner arrangements into EQIP. So some of this still can change in those summary statistics. So as a refresher, in the incentive payment methodology, after we have done your performance period results and reconciled across your EQIP entity and determined at least 3% of savings were achieved in that first box, and then we've applied your shared savings split based off of your relative efficiency or high-low cost ranking within the state, we will then move on to apply a clinical quality score. This clinical quality score will be 5% of the incentive payment that you've achieved after that shared savings split. We'll essentially take 5% out. And then based off of how you did on quality or your EQIP entity did on quality in that year, you will be able to earn back a portion of that 5%. You can earn anywhere from 0 to 100% of that 5% back for the performance year. After that quality score is applied, we will then do the rest of the incentive payment calculation, but this is really one of the final kind of performance checks in that reconciliation and incentive payment methodology. Are there any questions on this, how this works in the process here? We'll keep going, but please feel free to jump in with questions and comments. Okay, so when selecting the EQIP quality measures for performance year 1, we did want to have a unified quality approach across all episodes and episode specialties. And so we took an approach where we looked at measure characteristics, QPP standards, and some priorities of the HSCRC. When we looked at measure characteristics, we really wanted to find something that fit within MIPS. So it was applicable at a physician level, not a facility level, as we typically do with HSCRC programs. And then we also did want to find something that was measurable off of Part B claims. We did not want to set up a process by which you were connecting your EHRs to our program or finding a way to submit monthly data. We really wanted to be able to measure it at the HSCRC and CRISP level to reduce burden of participation for participants. We also had to maintain some CMS quality payment program or QPP standards. So we needed to ensure we were looking at measures that were high priority or outcomes based, and we needed to find at least 3 metrics for this first performance year to meet those standards by CMS. And then finally, at the HSCRC and alongside the total cost of care model, we have a number of ambitious goals, including alignment with other payers. So we did have another bundled payment program operating in the state via Care First, but we wanted to find a way where possible to align with other payer programs if applicable. We also wanted this, as I mentioned, to be agnostic to episode type to reduce reporting burden from everyone. And then we also wanted to find a way to integrate this with our statewide integrated health improvement strategy, which is a broad population health and health system initiative that the state has committed to with CMS. So once we looked at all of those kind of buckets of characteristics, we boiled down to 3 main measures, which are advanced care plan, documentation of current medications in the medical record, and BMI screening. All of these are billable services. We've listed the CPT codes that we will be measuring over to the right. So on the left-hand side, left column, you'll see the CPT or G codes, especially for BMI. I would note that. But also that we've allowed for tracking codes. So codes to be implemented onto claims that are non-billable, but essentially say, yes, this service was performed per CMS standards. So we will be looking for, we've performed an analysis where we look for these codes within the 364 days preceding the end of the episode. So we look at the end of the episode in the baseline, and we look 364 days back to see if these codes were performed by any provider to the beneficiary that the episode is applied to. So a pretty broad measurement. We're hoping that these help to advance coordination among providers and also advance some key process measures for the state.
You see the 2 questions in the chat, Maddie?
We'll pull them up.
Do we have target benchmarks for each quality score?
So you will have benchmarks for each quality score. We will get summary files out to you in that first week of January.
And the next question is a little longer.
Yes. I do understand that there is a bit of a coding discrepancy, especially with what is done under ECQMs. The BMI and follow-up measure is still used in MIPS. So it's not the NCQA measure. It's a BMI, a MIPS specific metric that we are utilizing there. I'll say also, Sharon, that we are planning to do some TA through CRISP on these quality metrics to kind of think about what operations process is best, because I recognize, some programs having ECQM submission versus this being purely claims-based, the implementation is going to be a bit different, though we're hoping to make it as least burdensome as possible. So I know you've shared a couple of thoughts with me already, but if there are additional thoughts and comments on ideal operations or measurement, please let me know. Next slide.
Just a quick question. So this seems to be more primary care kind of thing. So for specialists, are there any different measures for like cardiologists? We don't do advanced care planning or.
So a part of the theory of change, and we'll get into that a little bit, is not that cardiologists should do advanced care planning if that's not regularly within their scope of practice, but coordination with the primary care offices or those providers that typically do that care would be an excellent addition to the value-based care that we're implementing here. I think it generally, when you're putting someone under anesthesia, as for most of the quality or cardiology episodes that exist, it's generally a good thing in this population to ensure an advanced care plan is in place. It doesn't mean that the cardiologist necessarily has to be the provider that does that, but we do think it's important and a good metric of quality that providers are checking the advanced care plans prior to putting someone through surgery. So we thought that these were a good way also to connect to primary care and that continuum of care quality. So that's a part of our approach with this, with these quality metrics.
And I think just to say on that particular one, that's one that MedChi is actually doing a little bit of work on with CRISP right now separately, not Jessica, other people who work there. And maybe there's some economies of scale if we can figure out how to address these quality measures, and then we can do some cross learning. Maybe there's a way that we can try to address advanced care planning for EQIP in an intelligent way that could help us all be successful. And that might be something we can work on in a subgroup, either at MedChi or through this group. But I do think we can figure that out. It's very doable. It's not that complicated, and you can actually bill for it. So for those of you who are focused on the economic benefits of this, figuring out a way to do this, you can actually bill for the time involved in doing that. So maybe that's something we can do a little more work on separately or offline.
The tracking codes are just, you've ensured that there's one available in the medical record to you as a provider. So a fairly easy practice within.
Right, and when I said billing, I meant for the higher level advanced planning. That's what I'm referring to. You do have to do 20 minutes and there's additional coding, but you can do that, and then that gets you obviously compliance with the quality measure. So that's what I was referring to.
So we'll go through, we've gotten into some of this, but some of the benefits for advanced care planning. And I do want to introduce Dr. Allison Schuster, who heads up some of our quality programs at the HSCRC, who's helped look into some of this theory of change. I'll just go over it generally, but again, we do think that these are good metrics across all procedural and acute based episodes. So advanced care planning, it promotes that patient-centered care and focuses on individual preferences for care and treatment. It also removes the decision-making burden from loved ones and prevents downstream effects and costs from prolonging these things. And then also can improve patient experiences for those high risk and high needs patients. So while it's also always a good thing to check, we also think promoting that patient-centered care is important here in EQIP. Next slide, Jessica. Documentation of current medications in the record. This is prescription medications and multiple prescription medications is very common among older adults, especially the Medicare population with chronic conditions. Around 18% of people 65 and over take 10 or more medications at least a week. So again, checking for any sort of complications with anesthesia drugs, with post-discharge drugs, ensuring that that episode and the procedural quality of care is maintained. Medications, I'm sure, are a big part of that plan. It has been found in literature that providers do tend to have less than adequate care coordination, and it makes accurate medication records difficult to collect. So again, promoting that coordination, that good handoff from provider to provider across these episodes is important to us. And then also reducing any adverse drug events, making sure that we're not increasing length of stay due to any avoidable admissions, mortality, avoidable care that can be provided by this intervention, we think is important and helpful. And then there have been studies that have shown that increases in EHR use has been shown to reduce medication errors and adverse drug events. So again, utilizing that certified EHR technology, really implementing handoffs across different health systems and patients is important to us here. Next slide. BMI screening and follow-up plan. Our statewide integrated health improvement strategy, or SIHIS, has actually set a very ambitious goal for the state of reducing BMI statewide. So we wanted to make sure that we are hitting on this among others, this goal among others, in as many value-based payment programs and incentives that we can across the HSCRC. So given that more than 1/3 of US adults are obese or at increased risk for diabetes and cardiovascular disease, we think all providers should have an eye on this BMI screening and intervention, especially if someone is undergoing a surgery, and especially if someone is undergoing that anesthesia or receiving hospital care during an acute episode. Despite many effective interventions being available, a majority of obese adults are not counseled or offered weight management beyond that primary care office. And so again, we think the more touches that patients can have with providers who are concerned and screening and following up with BMI, the better outcomes we will have for patients across Maryland. And then again, this critical improvement for population is very important for not only cost reductions, but our overall long-term trajectory in terms of healthcare spending and quality. For scaling and performance thresholds for these measures, we will assign quality points to each measure or give each EQIP entity a score based off of their quality performance during the performance year relative to statewide thresholds. So this is an important piece. You are not relative to other participants in the program. We set these thresholds based off of every episode that was in the baseline year. For the state. So this is done statewide for every possible knee arthroscopy episode, for example, across all of our programs. We did do analytics to make sure that there wasn't discrepancies that were palpable among different specialists in the program. So there wasn't any undue advantage for being an orthopedist versus a cardiologist in these episodes or in these quality metrics. And we did feel pretty confident after doing those analytics that there was no kind of disparity between different specialties. Performance thresholds for this first performance year will be determined based on data for the 2019 baseline EQIP episodes, similar to the target pricing. Once you see these performance thresholds, you will understand that we are withholding the right to update those performance thresholds in future years to reflect relative and necessary improvements. They're fairly low. And so as we improve as a state, the HSCRC does reserve the right to increase or update those performance thresholds. Though at this time, they are planned to stay static until that decision is made and that future quality progression plan is laid out to this work group. For each quality measure, the distribution of performance rates for all baseline care partners will be used to determine the performance threshold specific to each measure. So we took essentially all care partners with an episode in the EQIP entity and utilized their distribution of the quality metrics within their performance. We then went and set the 80th percentile value of the baseline distribution to constitute the top threshold of the state, and those EQIP entities that would, if receive the maximum number of points, so 10 points essentially for that quality metric, is set at the 80th percentile of the state. And then we went and set the 20th percent, or found the 20th percentile within the state, or the bottom threshold for the performance here. And anyone below that 20th percentile we determined would receive 0 points. So anyone above in the top 80% in the state will receive full metrics on each quality measure, and anyone below that 20th percentile will receive 0 quality scoring. Again, these benchmarks were set on a statewide experience, not participant experience. We do anticipate that you being an EQIP participant will mean that you have more eyes on these 3 quality metrics and thus can really easily be outside of that 20th percentile in the state.
Maddie, there's one additional question.
Thank you for keeping eyes on that. The care measures, do we need to submit the F code in addition to the G code? Again, I'm going to defer this to that TA that we have planned with Chris. I'm not sure on this, so I will give myself a deferral there, but we'll follow up on that. That's a helpful question. Go to the next slide. So then once we get each quality, for each measure, the quality points that an EQIP entity earns, we will then go to apply the composite quality scoring methodology. So we will score the quality measure at the EQIP entity level. So we'll get the performance rate of the EQIP entity, which is essentially the summation of all of the measure flags over the total count of episodes. We will then aggregate the measure score, and you can receive up to 30 points for 3 measures. So 10 points each if we will aggregate across your entity. And then we will convert that to the CQS. So it will be equal to the sum of the points earned on all applicable quality measures divided by 30. So essentially 0 to 100% of the 5% you will earn back based on your score of 30. A lot of numbers there. But I think once you see the thresholds, it'll make a bit more sense. So let's go to those and then we can circle back to this CQS calculation. So we'll actually talk about this first, sorry. We can do that. I will mention that because this quality component is very important for the CMS quality payment program, including that 5% Part B or macro bonus and MIPS exclusions, it's really imperative that we have strict quality standards to ensure that we're maintaining good quality per the vis-a-vis the federal programs. Therefore, we do have a policy where we will involuntarily remove EQIP entities who achieve minimal quality performance. That is, they are below that 20th percentile benchmark threshold in 2 consecutive years. So if you are below that performance quality, that 20th percentile threshold in the first year, we will essentially put you on quote unquote probation. And then 2 consecutive years of low or no quality performance, we will remove you from the program. Again, these benchmarks are based off of statewide experience, not EQIP participants. So if you are an EQIP participant, we anticipate it will be fairly easy to break through that 20th percentile benchmark. And as we mentioned, that'll be available the first week of January. So for advanced care planning, if you look on the left-hand side, this is the quality performance rate. And then the middle column will show you the points that we assign for the performance year if you are within these brackets. So our 20th percentile in this metric was 7.63%. So that means only 7.63% of all episodes received an advanced care plan code. So only 7% of patients across all of our episodes were actually receiving that intervention. You just have to do better than that. So reach over 7%, though we hope that you strive for more as you can earn increasing points on this metric, the more percentage of your beneficiaries that have an advanced care plan applied within their episodes. The maximum number of points for this performance year or the maximum number of points for this performance year will be achieved if you reach over 29% or so of your episodes or patients receiving an advanced care plan. So only 30% of your episodes for performance year 1 receiving an advanced care plan will get you full quality scores on this metric. We can go to the next one. For medication reconciliation, this is a
And
little
just
bit
before we leave that one,
Okay.
all that has to happen on the advanced care plan is that some practitioner needs to build a tracking code during the year performance year. So it's not as burdensome as one might think. It's not the full 20-minute code that, although it makes sense to do that if you want to bill for it, that's all that has to happen. Correct, Manny?
Yes, exactly. It just needs to be connected to the beneficiaries in the performance year.
Right.
Was there a question? Okay. So for medication reconciliation, the threshold benchmarks are a little bit higher here. So that 20th percentile benchmark is around about 17% of patients receiving a medication reconciliation code on their claims. That scales up to the full points awarded at 42% of patients receiving medication reconciliation interventions. So a little bit higher here, though, again, we do think more providers are performing, we know more providers are performing this activity, and this is reflected in the statewide benchmarks here. This one. And then finally on BMI screening, this is probably our lowest benchmark. This is our lowest benchmarks. At the 20th percentile, we have around 4% of patients. So you just have to break over 5% of your patients achieving or receiving BMI screening and intervention, scaling up to 21% of patients receiving that BMI intervention. So this BMI metric, in addition to most notably the advanced care planning metric, these thresholds are pretty low. in terms of what you need to achieve. We anticipate that our EQIP entities will put a lot of energy around this and all be very successful in achieving these thresholds. So thus the HSCRC is reserving the right to update, though they want to outline these plans with this group and ensure that there is stakeholder buy-in prior to that. But we do want to keep striving for more than just 21% of our patients in the state receiving BMI screening. We want to achieve closer to 100% of those who do not have an exclusion marked on their claims. So we think that these are good interventions for all Medicare patients in the state, and want to strive to create incentives to do that. Are there any questions on these thresholds? Great. So those will be the thresholds that your performance year performance is compared to. When we look at the baseline results for EQIP entities, and again, this will be available in CRISP in the first week of January, we wanted to just give some summary statistics to say what we were looking at across EQIP entities. For advanced care plan, right now we have about an average performance rate of about 25% of patients who are attributed to our EQIP entities receiving this intervention. Our lowest score is 5.8%, with the median being around 17%, and some EQIP entities actually being close to 100% for their performance on advanced care plan. So this variation as well tells us that this is possible for EQIP entities to get as close as possible to every single patient receiving advanced care plan interventions for our EQIP entities. So a lot of variation here and a lot of opportunity if someone is already achieving a 98% rate. We will have 5 EQIP entities should they not do anything with their quality metrics that will be on probation after this first performance year. We will let those EQIP entities know, hey, if your performance year rates do not change at all from what you did in the baseline, you would be on probation per the program and be subject to removal if 2 years of this consisted. We want to be transparent about these things and let people know where they have room to improve, so that way everyone can be successful in the program moving forward. For medication reconciliation, the average is a bit higher, around 31%. That's also reflected in the benchmarks. We have the minimum rate. We're not even close to zero there. It's around 13%, scaling up to a maximum rate of about 77 or 76%. So a little bit less than the advanced care plan maximum rate, though we do think getting us close to that 100% threshold, or the 100% mark of all patients receiving this is feasible. For this metric, if we were to put people on probation tomorrow, we would have 3 EQIP entities on probation out of our 52. And then finally, for BMI screening, again, this one has the least amount of penetration, though it is very important to the state. We have an average of about 15% of patients attributed to our EQIP entities in the baseline receiving this intervention. We do have some EQIP entities who have a rate of 0%, which is very concerning to us, and we want to improve upon that. Up to some EQIP entities performing this at a rate of about 63%. So again, a lot of variation here. All this tells us is that this is possible, and there are some that need to more rapidly improve. The count of probation that would be here, again, this is our lowest of thresholds at around 5%, would just be 2 EQIP entities. So we think that we've appropriately set these threshold benchmarks in a way that puts some fire under those who really drastically need to improve quickly, but then also creates achievable standards for people moving forward, or for EQIP entities moving forward. So that way they can be increasingly improving their work on these interventions.
Maddie, this is Sharon here. Can you hear me?
Yeah, Sharon.
I know, Maddie, we have discussed, and I think this is a follow-up to the I think comment that I had in the chat as well. I 100% agree that quality improvement on all of these 3 measures is like absolutely the top priority. And these are the measures actually that we are working on with our primary care practices, not only for our Maryland primary care program, but various other value-based care contracts as well, right? Mm-hmm. Having said that, again, the reasons, these numbers, again, I'm not just speaking, I may be wrong. The reasons for these numbers being low for BMI on MedRec is that we have always been teaching our providers for some of the requirements for other value-based care programs as purely ECQMs, right?
Yeah.
So these measures are being documented, the education, the training, all of the bills that have happened within the EMRs for these coordinating measures have been done so that we could report from an ECQM perspective. And now this program is claims-based, right? So there comes another component, added component to it, that we may have to build those measures within the EMRs, right? Re-educate the providers to make sure that they drop those claims-based codes so that they show up on the back end, right? Because these measures are going to be measured from a claims perspective. So I 100% agree with these measures, because we work with these measures all day, all along with our primary care partners. But these measures have always been built, educated from an ECQM perspective, and now there's going to be a shift to a technical component. And as I mentioned in my chat, some of those CPT2 codes, F codes, are even not available. They are not even viable to be built or dropped. So there are some limitations with regards to the CORDI measures, how they will be reported, or how well some entities may or may not perform.
Absolutely. I understand on implementation and technical consideration. There are probably going to be a couple of questions and hoops to jump through. I will say, we couldn't create this perfectly for anyone who was ever in another value-based care program or another program. We did not want to rely on ECQMs for a myriad of reasons. There's cross-sectional with EHR vendors that we also had to consider, but I think that it can be, and I'm not going to be an expert here in ECQMs. I don't know if Allison or William, you guys have thoughts here, but I do think that there, with the tracking code inclusion, there can be a very simple technical fix on the practice side. So that way you're not doing double duty in terms of trying to get the ECQMs and these claims-based measures in, but there's a simple technical kind of fix to ensure when you're doing one, the other is also applied. So I don't know, William or Allison, as more of our ECQM experts here, you have additional thoughts, but we're willing to support on the technical side via Chris, but we really didn't want to go with ECQMs to reduce provider burden, especially for our smaller practices in this sense.
100% agree, Mary. But again, some learning sessions going into the new year, I think would be very helpful, right? As we start talking some details, similar to some of the other programs that we have had. The support, the learning sessions are really helpful for the practices as they start thinking about implementing some of these components.
Yep, absolutely. And Jean and I have spoken about that. Jessica and him will be working on a CME session. And I wonder if there's some of that technical implementation piece that we can include in that, Jean and Jessica.
And I'm very open if you've got a handful of folks who want to have a smaller group to discuss on how we can be successful on these quality measures. And MedChi would even be willing, if it made sense, to maybe think of a way that we can provide some level of service to help people be successful. Because I think to the cardiologist, and I'm sorry, I forgot which doctor it was who spoke earlier, if it's not part of their workflow plan, maybe there's a way we can figure out how to do it or integrate it with the primary care doctor who's appropriate with the patient, so we get these things done and people are successful in EQIP, and the quality measures don't become a deterrent to actually being successful in receiving a shared savings award.
Yep, thanks, Jean. So Sharon, we'll definitely follow up on those TA sessions and then look internally as a state to see if there's any integration that can be done with what's done on the primary care side.
Yeah, Maddie, this is William. I was just going to add, I mean, there is a CRISP level initiative for ECQMs on the practice side. I'm not that close to it. My understanding is the focus is in primary care. I don't think it's going to be in place for 1-1 by any stretch. But I think it's certainly something we can look to transitioning to in the out years.
Great, all helpful and kind of development further. Next slide. So we've mentioned this before, but I do want to put it on your radar again. Future performance year quality will continue to be developed. This is very important in the episode quality improvement program. It's very important to us as a state and also to CMS, who allows us to implement this program. So some areas that we are looking into adding for quality components are the Prometheus episode grouper does have a potentially avoidable complications flagging mechanism. So for example, colonoscopy episodes could have flags for codes that indicate a perforation or abdominal abscess exists post colonoscopy. So we could think about integrating some of that methodology into a clinical quality score component and scaling performance based off of that. And those definitions are available in our episode playbook. And if you want the specific codes, we can give you to those ad hoc. We also are very interested in finding more alignment with SIHIS. There's also an ambitious goal to reduce opioid mortality within this agreement with CMS. So we are looking into thinking through, is there an appropriate prescription metric that we could apply in terms of quality? Again, any alignment with MDPCP, as we just mentioned and discussed on the ECQMs and other physician touching programs, we are very interested in promoting. We also want to continue to promote health equity and address health disparities with everything that we do in terms of incentives at the HSCRC and specifically here with EQIP. So to the extent that we can integrate that with a quality approach, we are interested in exploring that. Additionally, as we have these site neutral target prices and we are incenting some shift out of the hospital into outpatient surgery and ambulatory surgery centers, we want to keep an eye on quality in those areas. So we are looking towards finding metrics that incentivize facilities with good quality performance over poor quality performance, and that we're keeping the same good eye on outpatient quality that we do on the hospital side of things. Again, with anything that we do, we want to find things that can be measured at a physician level and as close to episode specific outcomes. So if you look at those first three that we have, those are episode agnostic. We are interested in getting some more episode specific metrics in place at a physician level moving forward for future performance years. So we are anticipating that your first year of entrance into the program, you'll have those 3 baseline process measures. And then after that, we'll add on episode specific metrics. And then finally, patient recorded outcomes measures are increasingly important on the federal side. It's they're a growing area of a quality measurement nationally. So to the extent that these PROMs, as they're called, can be applied to EQIP, we will be looking into that. And again, we have Allison Schuster on, who leads our quality efforts here at the HSCRC, and she'll be helping lead us on this effort. I don't know, Allison, if you have anything else that you want to add on future developments, but you got a lot of interesting areas to look into with this work group.
And nothing to add, Maddie, but just to say it's nice to meet everybody, and I look forward to working with you as we try to add and evolve our quality components of the EQIP program over time. So, thank you, Maddie.
Okay, so next slide, Jessica. So just to close out, baseline dashboards and data will be available January of 2022. Our performance dashboards will be available March of 2022 once we start getting some of those performance episodes and their claims run out finalized. These dashboards will include detail on items like the potentially avoidable complication costs and rates, the place of service costs and rates, and then quality baseline and performance as well, among other things. Our plan is also to release DEX or raw claims data sets for EQIP entities who are interested in performing their own analytics, having that connection to their patients and more data within their own systems. Again, we can't release this until we have all of the providers signed in to the program. So once EQIP entities have their full set to us, we can start to release that in January. We do have a forum where it is encouraged that people provide any insights and thoughts on what they would like to see in reporting, any questions that they have. These are dynamic reports. We do want to improve them year over year. So if there are things that would be very helpful to have insights built out on, please do use this link and provide some comments there. I think this forum also, I'll mention, is just a good place to go and post questions. Also see if other people have already asked the question that you are sort of chewing on at the time. We're really trying to encourage these open access feedback forums in future policy and development. Jessica, if you want to add anything here, this is more your wheelhouse.
No, I think you covered it. Yeah, we're hoping that if there's questions and some shared learning that we can just get some easy answers and have a running list of probably concerns that multiple participants have.
Great. And then final slide, I think. Any final questions? I want to open it up. We do want to strongly say, as Jessica said, she's very hopeful, but we only have 3% of all of the care partner arrangements back. So we are really pushing that December 31st deadline is the deadline for providers to get their care partner arrangements either in or into UMS. So there's the emails provided in one of the earlier slides of this deck. But if you have any questions, please feel free to reach out to equip@chris.health.org.
Hey, Maddie, it's Dr. Grasso. I have a question. I don't know, you're probably not going to be able to answer this, but I know there's some folks from HSCRC on the call. Where does someone go? I thought it was supposed to be public information to find out what the episode costs, the cost for cases that HSCRC sets for the rate set at different hospitals.
So cost for a DRG or for
a CPT code or DRG, either way. I've been on the HSCRC website for hours and it's all very obtuse and seemingly designed to make sure no one can understand what the costs are. I don't know how we as providers can compare hospitals as far as places to take patients to if we don't know what the HSCRC rate set is for those hospitals. We're going into this EQIP thing, like I said, totally blind. And, we got hospitals that we know the costs differ widely between different hospitals. Most of our providers are credentialed at two or three different institutions. It would be nice to be able to provide them with that data.
So I think there are a couple of different areas, but Will and William, please jump in as well. We do provide all of our rates and rates by hospital at a rate center basis on our website. So I think that's a good source, as well as any claims that you guys are getting back as a practice can start to give insights on that cost per procedure and cost per different hospitals. On a CPT and DRG level, I'm not sure if we do anything specifically publicly, William, but I'll let you answer that.
No, not because we set the rates, as you said, at an individual code level. That we don't set rates at a DRG level, so we don't have DRG rates. I believe MHCC does have a cost transparency site that
which has very little data on it. I've been through the entire thing. It's very sketchy, and there's not a whole lot of data, not a whole lot of hospitals that provided the information.
This is Will from the HSCRC.
Yep.
On our website, we have a page that's titled Hospital Rate Orders and Unit Rates. On that page, there is a spreadsheet, and it has every single hospital in the state that we set rates for, the cost center, and the cost for the rate for that cost center. And it's a pretty simple spreadsheet, and we're happy to send it to you or send you the link.
I've looked at it, Will. It's impossible for us to get any useful information, at least to this point, we haven't been able to get any useful information off of it. But if maybe we could talk offline and you can explain to me how I can get the information I need for my guys to make good decisions off of that spreadsheet.
Sure, we'll be happy to set up an analytic session for you.
Okay.
So I also wanted to mention a bit of personal news. I myself will be leaving state service next week. So this is my final EQIP subgroup with everyone on this call. I am not going far. I'm going to University of Maryland. So I will still be paying close attention to EQIP, but I want to thank all of these stakeholders for all of your insights and help over the past couple of years getting this program stood up. I think it's going to make the model better in the state and be a great opportunity for our specialist providers. So thanks for working alongside me on that.
So on behalf of everybody, Maddie, I just want to thank you for everything you've done. You've been the one constant with this program from the very beginning who's worked on it, and we wouldn't be where we are today without you. So you should be really proud of what you've accomplished with this. And we're very sad that you're moving on, but we're also very happy for you personally, because it sounds like it's going to be a really exciting opportunity to do great things.
Thanks, Jean. I really appreciate that. And you guys will be in good hands with all of our HSCRC folks here on the call. Will and William have been constants as well. Jessica at CRISP has kept all of us organized within this, and Allison is going to be a great addition to the quality team. So I'm hopeful that we are leaving you in good hands, and I'm eager to see where this goes.
All right. Anything else for the good of the order? It's your last shot.
I'm all good.
So everything's great, and Maddie, you're leaving. That's the way to do it. All right. All right. Well, thank you, everybody. Have a great weekend, and a happy new year to everyone.
Thanks, Jean.